Hi, Doc. Can you hear me? Yes.
Can you hear me?
Yes, I can, Doc.
Okay.
So I know you're also in a position to. I've put you as a presenter.
Okay.
So you're in a yes. Share your screen as well.
Okay, so I need to share the. Are you people able to share it?
Yeah, you see here.
Okay. Let me try that and then I'll let you know.
All right.
You can also share.
So I need to give the presentation.
Yeah.
Hi, Doc.
Yes. I can see the presentation.
Okay.
Okay. Okay.
So you're not going to name.
And then I should have my presentation standby. And then I should.
Good evening, colleagues. Welcome to this session. This evening, I want to thank you for those who have already joined us. We will just have a brief round of introductions from wherever you're joining us before we set things rolling. I just want to confirm whether Dr. Omedo is in the call. Dr. Omedo?
Yes, I am.
Yes, how are you, Dr.
I'm fine, thank you.
It's long since I passed by Kisi.
Karibu sana.
Asante. So I think we will just give ourselves a few minutes. Seeing members are joining in. And as I say, I want to appreciate those who have created time to join us. So I just want to give us some 5 minutes. You can unmute and just tell us where you're joining from as members join in before we officially start our webinar. Remember, this day we are so privileged to have one of the seasoned hemato-oncologists, pediatric, Dr. Deborah, who will take us through this very important topic on to children with life-limiting and also life-threatening conditions. And I can agree with all of us. It's one of the challenging kind of experiences which we will share later. So just unmute and just greet the community and tell us where you're joining from. Karibu.
Hi, Raphael. Good evening.
Good
I wish
evening.
to welcome everyone for joining. Apologies, it's only the presenters who are in a position to unmute, so maybe we can allow them to type in wherever they are. This is Emily from Kehpca.
Yes, thanks, Emily. And I forgot even to allow you to give intro and just welcome us to this discussion. As Emily has guided us, we are unable to mute ourselves. So you may just drop in your name, your specialty, and where you practice, just to have it more engaging. And as we officially start, we will encourage us also to utilize the Q&A session. If you have any question, let's start putting in so that we can, keep record of it. And so that when we are the tail end of the discussion, then we are able to answer those questions. There will be moments when we will allow people to ask live questions. So for now, I would also give Emily some few minutes just to, if you have any further instruction or direction relating to our session tonight. Emily.
Good evening again, everyone. My name is Emily Masharia, and I work with Kehpca as the liaison officer. I have also been planning for the webinars, and I wish to thank everyone who has been joining in our series of children's palliative care webinars. We started in December last year, and with support from HCK, that is Hospice Care Kenya, we are continuing. And this is to request everyone to keep on plugging. Let us know how we can support our children wherever they are. Yes, so it is to welcome everyone else. I am joined by my colleagues from Kehpca. I know we will get to know them a bit later, but on the call is our Executive Director, Madam Makili Natieno. We have Dr. Esther Muinga, and we have Paul Kuto. So we are here as Kehpca. We also have our Director of Programs, David Musioki, join us. So thank you. We are here as Kehpca to advance integration of palliative care in Kenya. And so we believe that we will all be part and champions of palliative care wherever we are. Thank you for joining, and I look forward to seeing you in other series of such webinars, which will be hosting every other month. And over to you. Thank you. I have seen a comment from our Executive Director. Maybe if she's in a position, she can give a word, and then we will officially start. Makilin, if you're in a position. Okay, over to you, Raphael. Thank you.
Thank you very much, Emily, and thank you, Kehpca, for enabling this very important discussions that we've been, engaged through. And specifically, want to thank also the programs that are happening in Kehpca, especially the one touching on the children, palliative care. I'm a beneficiary, and I'm so grateful. So, colleagues, this evening, allow me to introduce our speaker. Just a moment. So we will be discussing issues communication. And as you can bear witness, it's one of the challenging areas, starting from just even diagnosis through treatment until when we are at the end stage disease. So we are so privileged to have our very own to share with us this important subject. Dr. Deborah Omedo Marigu is one of the pediatric hematologists, oncologists in the country, who has a very vast knowledge in working with children with palliative care needs. And has a great passion in children palliative care. Our main objective is to provide quality pediatric hematology and oncology services to the children living in Africa. It's important to highlight that our advance is towards quality care. Currently, she serves as the consultant pediatrician in charge of Department of Pediatrics, including the pediatric outpatient clinic, MCH clinics, newborn unit, and all the pediatric wards at the Kehpca Teaching and Referral Hospital. She also runs the pediatric hematology and oncology clinic at the same facility, and oversees the care of children with hematological conditions or cancer, and also moderates the pediatric multidisciplinary tumor boards. She has authored and presented in many conferences, many journals on matters children health. Her education background, she had fellowship in pediatric hematology and oncology at Mulago Hospital in Kampala, Uganda, in conjunction with Texas Children's Hospital, Byron College of Medicine, and Global Hope, that is hematology, oncology, pediatric experience. Our postgraduate was in Nairobi University, of course, in pediatrics and child health, the same institution she did undergraduate. She's a member of many associations, one Kenya Medical Association, Kenya Pediatric Association, Christian Medical and Dental Association, Kenya Society of Hematology and Oncology Society. While not working at Kehpca and other affiliate facilities or matters professional, she enjoys drama, traveling, cookery, and it's important to note whenever you pass by there, maybe you will enjoy a cake. And then swimming, puppetry, and adventure. So it is my privilege to welcome Dr. Deborah Omedo to take us through this important subject on communication to children with life-limiting and life-threatening conditions. Dr. Omedo, karibu sana, daktari.
Thank you so much. So welcome everybody to this presentation. Today we are going to talk about communication to children with life-limiting and life-threatening conditions. Next slide, please. Next slide.
So the slides are moving. Are you able to appreciate from your end?
No. Yes, now I can see.
Now go
So,
back a little bit.
Yes, thank you. Now I can see the next slide. Thank you very much. So when children have life-threatening or life-limiting conditions, they can still see, they can still feel. Okay, go back, please. Go back one slide. Oh, sorry. Is this the second slide? Let's go back to the previous slide.
Okay.
The second one. This is the third one. So I'll just carry on. Yes. So despite children having life-threatening and life-limiting conditions, most children can see, feel, hear, perceive, taste, and speak up to the point of death. And so their senses, some may be intact, some may not be intact, but it's important to remember that their senses are present, sometimes up to the very end, up to the point of death. Next slide, please. Yes, so what is communication? Communication is something that is perceived through all the senses. It is a two-way exchange of information, and a lot of it is done without words. Next slide, please. So communication can be verbal, and it can also be non-verbal. Next slide. Next slide, please. Yes, so when we have a child in a life-threatening or a life-limiting situation, we have to think about what we are communicating to the child in the room in which they are in, whether it's the acute room, whether it is the ward room, whether it is at home when they're receiving palliative care. Wherever there is, you need to think, what is the ambience of the place you're in communicating to that child? How is the room they're in? Is it organized? Is it disorganized? Is it dirty? Is it clean? Is it well ventilated? Is it too cold? Is it too hot? Is it really comfortable for that child? Is the room well lit? Are the bulbs working properly? Or are there some that are flickering? Is one able to see properly in that room? Is it child-friendly? Are there bright and friendly colors that would speak to the child? Is the room welcoming? Is the room comforting? Does the room have a foul smell? Does the room have a good view of the environment outside the window?
Dr. Meadow, are you on the call?
Yes, I think it's back. I think it could be a network problem.
Oh, sorry.
So, yes, sorry about that. So how is the room for this child? What is this room communicating to this child? Is it too noisy? On the other hand, is it too quiet? Is there a possibility of having soothing, child-friendly music for this child? Are the children's friends and loved ones able to access?
Hello, Dr. Meadow? Hello, Dr. Meadow? Sorry, we seem to have lost Dr. Meadow. I don't know. She has suggested some network issues. Let's give us some few minutes.
Sorry,
Sorry,
I think
Dr.
the
Medo,
network
karibu.
has been faulty.
Oh,
Sorry about that.
Karibu.
Yeah. Sorry. So what is the room communicating to the child? Is there a possibility? Yes. So is there a possibility of providing soothing, child-friendly music to the child in that room? Are the child's friends and loved ones able to access the room and greet the child and play with the child and talk to the child? So those are some of the things that we need to think about, even as we think about communicating with children with life-threatening and life-limiting situations. What is the ambience like? And it doesn't have to be a very expensive venture. It can be a grass-thatched home, but they make sure they have sprinkled water on the floor, and so that it is clean. It is possible that they can be able to take the child outside to see some fresh air at some point and make the place neat and clean. It doesn't have to be extremely expensive to make sure that the ambience communicates something positive to this child in a life-threatening and life-limiting situation. Next slide, please. Next slide. Hello. Next slide, please.
Hi, Doc. I am moving. I think your internet has a problem because I'm already at the facial expression.
Of the clothing, yeah? All right, let me just read from my phone. So is the clothing of the child warm enough for the situation? Is the texture of the clothing soft to the skin? Is the clothing something that can easily be put on and off, despite central lines, potocaths, and IV cannulas? Are the colors of the clothes friendly? Are there many clean ones to change to if the ones that have been worn have become soiled? Are the clothes well-fitting, and are they modest, or are they showing parts of the child that the child would feel shy and embarrassed to wear? Is the bed of the child well made? Are they comfortable, or are there lumps and bumps that can cause the child bed sores and pressure sores?
We sincerely apologize. I think Dr. Medo seems to be going through some network challenges. Apologies for that. Let's just hold on. She will be back. Me? Yeah, welcome back, Dr. Medo. Sorry for the network issues. Dr. Medo?
Sorry, I was using my Wi-Fi. I think it's back.
So meanwhile, you can drop your any question in the Q&A session, and also we can also chat. Dr. Medo?
She's trying to change to a different network. If we could just give her a minute.
All right.
So
Thank you.
hopefully
Thank you,
the other one will work better. Sorry.
Sure. Thanks, David. Thank you.
Doro. Wifi inakataa. Kuja niweke kwa Doro. Hello? Hello, can you hear me now?
Yes, Dr. Medo, we can hear you. Sorry for the hitches. Welcome
All right.
back. Thank you.
So what does the clothing of the child, all right. What does the clothing of the child communicate? Is it comfortable? Is it warm enough? Is it too warm? Is it soft enough to the skin? Is it something that the child can easily put on and put off, despite having central line cuts, intravenous cannulas? Are the colors friendly? Oops. Ahmad, you have in your phone. Can you connect your phone to the Safaricom?
Yeah.
Yeah.
Then you have to send me because I have 57.
Yeah, I can send you the money.
I'm sure it will take like a minute to get that sorted, and hopefully we'll be back. So good afternoon, good evening, good morning, everyone. We're sorry for that, but technology sometimes can be a mess, but we'll be back hopefully soon and with smooth learning. I'm sure we're all interested to learn quite a lot, matters communication and children, which is a very key topic. Many times when we're tending to children, and as adults, sometimes I'm sure we feel we wish to know how to communicate effectively, matters palliative care, and so this session is quite key. We could start a discussion on chat so that we're just not here sitting and waiting. And then once Dr. Omido is set, we will allow her to continue. Probably what are some of the big challenges that we find ourselves experiencing? Oh, are you back, Dr. Omido?
Can you hear me now?
Very well.
Yes, can you hear me now?
Yes.
Yes.
Okay.
All right. So we continue with the clothing of the child. Is it warm enough, or is the clothing inadequate for the weather? Is the clothing soft enough to the skin? Are they, can the clothing be put on easily and off despite the central lines, the portocuts, the intravenous cannulas? Are the colors friendly for the age and gender of the child? Are there many clean ones that in case the clothes get soiled, they can be changed? In case the child is sweaty or there's blood or any other dirty thing, they can get new ones in good time so that the child doesn't have to stay in dirty clothes. Are the clothes well-fitting? Are they modest? Especially for our adolescents and pre-adolescents who may feel shy if the clothes are not covering them very well. Is the bed well made? Or are there uncomfortable lumps and bumps on the bed? Has the urine bag been emptied on time? Has the diaper been changed on time? Is there privacy as the child relieves himself or herself? So these are important things that are also part of communication to children in life-threatening and life-limiting situations. What are our facial expressions like? What is the facial expression of the caregivers and the health workers? Is it a reassuring facial expression? Is it hypocritical? Is it friendly? Is it intimidating? Is it empathetic? Is it genuine? So as we communicate with children, we need to remember that our facial expressions mean a lot. You could have words that sound so good, but the facial expression may be something different that may communicate something different to that child. And children look at more of what we do more than what we say. How about our voice while we talk to the children? What is the tone of the voices of the health workers and the caregivers? Is the voice friendly? Is it too loud? Is it too soft? Is there too much medical jargon such that the child cannot understand what you're trying to communicate to them or to their parent? Is the tone friendly towards the child, their parent, or their caregiver? Is the tone reassuring? Is the tone hypocritical? Is the tone empathizing? Then in communication, we must learn to listen. It is said that we have one mouth and 2 ears, meaning we are supposed to listen twice as much as we speak. Do we take time to listen to the child in this life-threatening or life-limiting situation? Do we encourage him or her to express herself? Do we allow her to ask questions? Do we answer the questions that the child has asked in an honest way in which the child can understand? Does the child have a say in how they want their last rites to be carried out? Has the child been given a chance to write or express their last wishes or their own will? Has the child been given a chance to say their last goodbye to their friends or loved ones? Then play therapy. Has the child been given a chance to play even though they are bedridden? Are there a variety of play activities that the child can engage in to prevent boredom and distract from the pain? Are there reading materials available? Are there writing materials and coloring books and crayons available? Are there child-friendly educational and playful programs or, on the phone or a tablet or even on the screen? Are there bubbles for the child to blow? Are there crafts that the child may engage in, such as knitting, painting, modeling, and making beads? Can they be allowed to play a musical instrument? Can the child be allowed to record their voice or written messages for their loved ones? Who is in a life-threatening or life-limiting situation? How does the food that you give communicate to this child? Is the food easy to chew and digest? Does the food taste good? Is there enough water or fluid for the child to prevent dehydration? Is the food in sufficient amounts? And is it of good variety? If the child is on an NG tube, is it being changed every 2 weeks to prevent complications? If they're on a gastrostomy tube, is it clean? Is there infection around the skin? Is it being used correctly? If they're on intravenous fluids and and feeds running? Are they running at the right rate and the right proportion? How about grooming? Grooming of this child in a life-threatening and life-limiting situation. Has the child been given a bed bath in sufficient privacy for age? Do they want their hair styled? Do they wish to wear a wig or a cap? Do they want to put on makeup or paint their nails? Do they need a mirror to look at themselves? Have their nails been trimmed? Has their skin been well oiled? Can we make them look and feel their best despite their deteriorating clinical situation? How about touch? Can the child benefit from gentle massage? Can the loved ones and health workers appropriately show affection for the child? Can the cleaning and dressing of wounds be done as painlessly and as gently as possible in therapy and occupational therapy? And then we also need to look at the nonverbal cues of the child because they communicate a lot. Is the child happy? Anxious? Are they looking peaceful? Are they uncomfortable? Are they feeling embarrassed? If the child is the child afraid to speak out or express their true feelings? Is the child in pain or anguish? What is their FLAC score, where you are able to assess pain in a child who is not able to speak? Are they consolable? So with all these, the end conclusion of the matter is that communication is a two-way process. The goal of communication to children in life-threatening and life-limiting situations should be to make sure that the child is peaceful, comfortable, and dignified. Siwezi kuchat kama nina present.
I wasn't chatting with you.
You are please chatting to Masha.
Yes, I think Dr. Meta will be back in a short while. Meanwhile, a lot of questions have been asked there. Listening to her and just looking through those questions from ambience and to touch. They are very important questions which has been asked. And so as we, yes, Dr. Meta, welcome back.
Yeah, so the conclusion of the matter is that communication is a two-way process. The goal should be to make sure that the child is peaceful, comfortable, and dignified up to the very end. That's the end.
Thank you, Dr. Omedo, and we sincerely apologize for the itches that has been incurred by network. As David put it, it is expected. Otherwise, thank you for successfully going through despite those challenges. We are opening our forum, and I guess we followed keenly as Dr. Omedo presented on the communication. And indeed, as I said earlier, he has asked very important questions that each one of us in various facilities where we practice have encountered and seen how these children are supposed to be taken care of. So I've not seen any question in the Q&A. Otherwise, I think if you want to ask a question, you can just raise your hand. I hope the team will be able to unmute you and ask your question. If you would like to share comments and just contribute to those questions that Dr. Medo has really put across, you are free to share your thoughts and your concerns, your experiences. Yes, you're welcome. Thank you.
About regarding one that they have seen children cry their heart out. And the question is about use of short-acting pain relief drugs, for example, fentanyl or ketamine, during the dressing of wounds. And I would say that, yes, it is advisable, work together with your anesthesia team and your pain team to make sure that you are able to make the dressing of wounds as painful.
Thank you, Dr. Medo, for that. I've seen an Anne from Evanson, I think.
Free as.
Yeah, thank you, Dr. Raphael. That's the same question. Eh? She has responded to it. I had put it on the Q&A.
Oh, sorry, I was not able to actually track from my end. Thank you for that.
Okay, thank you.
Emily, I'm not able to track my Q&A session from my end. Sorry for that. You may just want to raise your hand and then please ask a question or make contribution. Thank you.
So I've seen another question from Esther Muinga concerning how to communicate a bad message to the child. Is a very important question for children in life-limiting and life-threatening situations. So number one, you need to find out what the child and the family know about the condition. Then you need to find out how much they wish to know about the situation. Then you need to be able to explain the situation in a kind but honest way, not giving false the clear picture that you look at their body language, see whether it is causing harm, and acknowledge their reactions to it, find out if they need any clarifications, find out if they have any questions about it, and be able to comfort them despite the negative emotions that come with it. Let them know that it is okay to feel bad about it. It's okay to feel sad about it, and let them know that your team will work with them positively despite the negative message, and will do their best to make sure the child is comfortable and has a dignified end, no matter how bad the prognosis or diagnosis is.
Thank you, Dr. Medo. Any other question, comment?
Just a quick one, Dr. Omido, how do you handle shielding, especially from parents or loved ones, and especially based on your experience in Kisi, loved ones and parents not wishing or wanting their children probably to know what is happening, but the information to be given to them as guardians or as parents?
So it's important to educate them that the child knows a lot. The child is not a statue, is not a stone, is not furniture. The child can see their body language, has seen what's happening to children beside them. The child knows how they are feeling. And that if you tell a lie to the child, or if you withhold knowledge from the child will take it as betrayal, and it will work negatively in the long run. So you'll encourage them to know that it's important for the child to know the truth, but the truth has to be given in a gentle way, in a way that the child can understand, and that it will work against the child and the family in the long run if there are lies and there's hypocrisy, because many times the child can tell when people are lying to them or hiding something from them.
Yeah, thank you, David, for that question. Dr. Meto, just a representation from where I work. You find sometimes we care these children, and especially from our settings, and this is something that we have appreciated, that of course, palliative care services sometimes comes late, though it's encouraging to know that it's coming early. But as these children, you get them, there's a very high chance of cure rate. So curative intent initially was achievable. As you manage, things changes, and you realize we are not able to achieve cure. And so transition to strengthen on palliative care is emphasized. How do you manage that transition with a parent who initially was informed that we are curing this disease, or our call is cure, and yet things have changed along the way? How do you manage that transition from your experience in your setting, and even having shared widely among colleagues? Thank you.
Yes, thank you for that question. So indeed, you can start off with a goal of cure, but along the line, you might find that the disease is progressing despite all the treatment being given. At such a point, you need to sit down with the family and have a proper family conference where you show that at the beginning it was supposed to be for cure, and the chemotherapy had been given as was required. Maybe the surgeries were done as required, but unfortunately the disease is progressing, and that now cure is no longer an option, and now it is palliative. So in the Global Hope program, we had forms that we filled with the patients at the beginning of the diagnosis, on revealing the diagnosis, where we write the goal of care. And so once you have given the care, and now you have reached a point where you're finding that the disease is progressing despite the standard of care, you have to have a family conference again. And then now you need to have a different form where now you chart the next way forward, where now the goal of treatment is no longer cure, but now the goal of treatment is palliation. And then you can you give them the various options and come together to a conclusion on what would be the best option for that particular child and the family. So it's not an easy situation, but it's always, honesty is always the best policy. When things are not working well, you sit down with them and explain to them the situation, and now sit together and make a new strategy for what is happening. Another question I saw on the chat is about when the child has been friends with another child with a similar diagnosis, and unfortunately that child dies. How then do you communicate with the children who are his or her friends? So yes, this situation occurs commonly because these children have been together, perhaps in the ward. They have been speaking to one another. Their caregivers has been speaking to one another, and then you find that the child now has died. So it's important to have group therapy if the children are all together in a ward, to listen to their feelings, give them an opportunity to express their feelings. This can be done verbally. This can be done through drawings, through colorings, through diary, through written messages. And there can be a time of explaining what happened to that child, and explaining that it doesn't necessarily have to happen to them, and that they can still do well and survive despite what happened to their colleague. And then if there are rights, final rights that the children can participate in, like writing messages to their parent, writing tributes to their fallen friend, allow the children to express themselves. And if you can have even a chaplain or a priest who can come and have a time of prayers with the children to comfort them and to give them psychosocial support, that is also very, very important. Another question I have seen is about another question I had seen. Sorry. So another question I have seen is when the child asks whether they are going to die. How will you communicate to a child if asked if she is going to die, or whether the parents will be with them after seeing other child passing away in the same room? Yeah. So I think what I had said previously kind of answers that. And it's true, when there's a death of a child with a similar diagnosis, everyone is very fearful and feels very vulnerable, and the fears are valid. So the child needs to feel validated for their feelings, but also feel supported so that they can be positive about their own diagnosis as well. Yes.
Thank you, Dr. Meda, for answering those questions. I don't know if there is other questions, Emily, in the track, Q&A or the chat.
Yes, I've seen a question about whether euthanasia is legal in our country. Yes. So in our constitution, euthanasia is illegal. It is not allowed, but instead we do palliative care. With good palliative care, where you are able to manage the pain of the patient, whether the physical pain with a strong analgesia and psychological pain using psychotherapy, and economic pain using the social workers to be able to relieve the family of very huge expenses. Good palliative care, when utilized well, you do not need to have euthanasia, which is illegal. So Elizabeth of Kabuthi tells us that they use photography and memory books as a means of communication, especially in children with life-limiting situations. So they are able to look at their photographs and make a memory book so that they can remember when they were energetic, and they can look at their life's journey together, and their parents, and they can choose which photographs that they want in their memory books, and they can make the memory books together with their loved ones and the caregivers. And that memory book can remain away even after they have died. And other children can come and look at their memory books thereafter in a way to overcome their grief. And I think that's a good way.
Yes,
Dr. Someone is asking. Raphael, I hope I'm audible.
Yes, we can hear you.
Okay, someone is asking, how do I communicate to a child who is deaf and I do not know sign language?
So sign language is very, very important. It's a very important skill, and I think in the long run, it needs to be introduced to every school, every medical school, because we have many, many deaf people, and that is their language. However, the government has done a great deal in training health workers who are well versed in sign language. So like in our hospital, Kehpca Teaching and Referral Hospital, we do have health workers trained in sign language. And so we are able to call them whenever we have a deaf patient in the ward and we are not able to communicate well. They usually come and they are able to communicate with the caregiver if they are deaf, or even the child if they are deaf. So we need to make sure that as health workers, as much as possible, it's good to learn at least the basics of sign language. But also as hospitals and institutions, we need to make sure that we have enough sign language interpreters available to us at any time, so that we are able to communicate very well with the patients. Sometimes we write messages, although it is not as spontaneous as when the sign language is used. So sometimes if you don't know sign language, you can use writing with the patient, and they can write back notes to you. You can write a note to them and write back. But I think we have to realize as health workers that I think it's inevitable. It's important to learn sign language so that you can have direct and spontaneous communication with your deaf client.
Thank you, Dr. Medo. I've seen our first hand is up. I don't know if you can help him to unmute to make a comment or a question, then followed by Edgar.
Okay, as I unmute them, there's a comment here, some from Margaret Gitao. Some situations are difficult. You find that the child understand what is happening, and then the parents withdraw medications and follow up and start with mitishamba to this child who is helpless. So she says, kindly assist on how to go about it. Then there's another question that says, what is your say about play and drawing in communicating with children and their illnesses? What are the key highlights that we should consider? So I think, Dr. you can answer those two, and then I will unmute Wefwafwa and Edgar.
Thank you for those questions. So I will start with the one on play therapy. I mean, on the drawing, the art therapy. Once we had a child who had Down syndrome, had been very badly neglected in their family. They were actually kept with the goats. So the child had grown up being treated like a wild animal, very badly mistreated. Their teeth had never been removed, so they had 2 sets of every teeth, had never spoken. And they came to the ward with a medical condition, and we started treating the child, and the child had never spoken. The child was, I think, around 6 years old. Then we called our psychosocial nurse, and she started to have art therapy with this child. So when they started the art therapy, she took the black crayon and drew and was very vigorous in scribbling very black message on the paper on the first day. And as the child continued having those art therapy sessions, she later on opened up and actually began to speak. And no one could believe it, that this child who has never spoken now was actually able to speak, because they were able to express the anger that they were feeling and the discrimination that they had felt. And later on, we were able to educate the parents about how it's, even though the child has disability, how they can be nurtured, how they can be taken care of. We're even able to involve the dental team, and they were able to remove the extra teeth. And at the end of the day, the child was well, both with the physical illness that had brought her to the hospital, but even psychologically. And we were able to mend the relationship and the anger that she had built up for many days with the parents. And the parents realized that this child can even speak. This child is even capable of learning. And we were able to link them up with the resources for occupational therapy and any other needs that the child may have needed. And so I've seen the power of art therapy. We had another recent child who came to our ward. The child had a difficult social setup, had been born out of wedlock, and the mother had gotten married in a different county. And so as they were traveling back to Kehpca County, and unfortunately there was an accident. Unfortunately, the mother got sick and the mother died. And so the child was very withdrawn in the ward, being taken care of a relative who he had not lived with for some time. And the child looked so depressed. But when our psychosocial nurses came about, they started art therapy. And in the art therapy, you could the psychosocial nurse would interpret what this means. They interpret the journey that they had and all that. And then slowly, by the child being able to express themselves with the different pictures, they now came to the acceptance of what has happened. And later on, when we could see the child in the ward, they were no longer depressed, no longer scared, no longer fearful. They were now able to communicate and express themselves. And so now the child now was more cheerful, and now their grief was now better handled because they were able to express their feelings. So I realized art therapy is so important. If you have a nurse psychologists who have gone through art therapy, it's a very, very important way of communicating with children, because they're able to express themselves, they're able to even reveal to you many things that are happening in their home and the things that they have gone through. And it is very liberating for the child when they're allowed to communicate and they're allowed to come to terms with what has gone on. Yeah, so it's very simple. You don't need very expensive things. You can have crayons, you can have paper, or even just our biro and the back of one of the continuation sheets in the ward. And it reveals so much when you interpret what the child has drawn. It makes a very, very, very big difference. Yes, sorry, I forgot the second question.
Emily, what was the second question? Sorry.
It was a comment from Margaret. It's loading.
Yes, it loads. Maybe Wafapwa can ask a question or make a comment. Karibu.
Thank you so much, Daktari, for the very insightful presentation. I have really learned a lot. And it is me who still asked the question about death. And I'm still asking just to know a bit of it, as much as you have told me about use of the art therapy and all that. Are we in order at times? And at which stage do we tell these children? Because we have some stages that children don't understand what's death. And most of us healthcare workers, we end up telling them, he has gone to be with the Lord, he has rested. So sometimes when you tell them he has rested, they expect you to be back. Which exact terms that we should use so that we don't make even those remaining feel like, now if he has gone to be with the Lord, why am I also supposed to go, or something like that? At which stage and at which words are we supposed to use for those that are still on care to reduce anxiety and all that, so that they can be supported to continue with the care, especially when one of them dies? Which exact words? Thank you.
Thank you so much for that question. Indeed, when a child dies, it's a very sad moment for the health worker who has been caring for that child, the children who have been friends and loved ones with that child, and of course the family and friends of that child. And that sadness has to be acknowledged. You as a health worker have to acknowledge your own sadness and your own feelings towards what has happened. The children, as we said, are not pieces of furniture, they're not metal, they're not stones. They also observe what is going on. Many of them may have seen the resuscitation as it occurs, and many of them will have seen the lifeless body, even as we are trying to resuscitate. So in matters death, even when we are dealing with the family, it's important to use the word death and not use any other words that can be misinterpreted, so that they know that it is final. Then I think the bereavement counseling is very important. So there's one concept called anticipatory bereavement counseling. And that means that while the child is still alive and you're seeing that the child is likely to die in a short time, it is important to call the loved ones of the child and have an anticipatory bereavement meeting with them, where they are told that where they're informed about the clinical situation of the child, and when they're informed that it is possible that the child may die in a short while. And what I realized is that for those children whose loved ones have gone through the anticipatory bereavement counseling before the child has died, then after the child has died, we then call the team again to do now a bereavement counseling after the death of the child. I found their reaction towards the death is not as traumatic as for those who did not receive the anticipatory bereavement counseling. So that can be a very useful thing. When you find that the prognosis is not good, make sure that the palliative nurses and those psychologists and those trained in anticipatory bereavement are able to come and have a session with the family and loved ones before the death actually occurs. And then after the death has occurred, allow them to grieve, allow them to express their feelings of pain, and then be there for them, allow them to express themselves, and then make sure that they know that they can come back later for further bereavement sessions. So we book them in the palliative care clinic so that even months after, they can still come to the clinic and express how they are feeling, how they are doing. And if possible, you can even do home visits. And if possible, you can even have memorial days. Like you can have once a year memorial days where parents who have lost their loved one with cancer can come with their memory books and remember their child, and you can have a service where the chaplain even has prayers for their families and makes them feel comforted and makes them feel like they did not just lose their child to oblivion, that their child is remembered, and even if their life was short, it was a significant life, and the journey, however painful it was not in vain, and they can be of encouragement even to the other parents to press on to the end. So it is important to use the real words death. And there are nice resources if you look into the internet, and even in some of the books. I liked some of the books that used to be there during the AIDS pandemic, where they would have child-friendly books where they talk about death, how to communicate death to children. And sometimes you find now that they are very child-friendly, and you can use them to communicate in a way that doesn't invalidate the feelings of grief in the child, but makes them hopeful. It's still hopeful that they will be able to make it in honor of their friend who has left them. Thank you.
Thank you, Dr. Medo. Edgar, quick. Sorry, yes, Edgar prepares. So there is this question, Daktari. I don't know whether you had answered in the previous. So it says some situations are difficult. You find that the child understands what's happening, and then the parents withdraw medication and follow up and start, mitishamba or apple therapies to this child who becomes helpless. Kindly assist how to go about it. In essence, Dr. Even as you answer this question, there are children who really understand what the discussion is going through, and you find that the child is wishing that parents or his parents would follow what the doctors are saying. So how do you bridge that gap, and how do you enhance communication to bring the parents and the child together into this? Thank you.
Thank you so much for that question. It is a very common situation in our clinical setup in Kenya and in Africa. And I found out that it's not only just in Africa alone, even in the rest of the world, people believe in the evil eye, people believe in herbal treatment. And even in places like even England, like King Charles is said, though he has prostate cancer, he's also following some herbal therapies and something like that. So it is a common situation. I remember one case in point. We had a child with a retinoblastoma, and it was advanced. However, we had managed to put on palliative chemotherapy, and the mass was coming down, and we were now preparing for palliative radiotherapy, and the child was doing very well. And so, in fact, on the day now that we were to discharge the child to go for the palliative radiotherapy with a massive reduction in the mass of the tumor, the relatives came with a whole jerry can of herbs. And then as they were administering the herbs by force, by closing the child's nose, and because they were in a private room, the child choked and died from aspiration of the herbal, the jerry can of herbal of herbs. So it is important that even at the very beginning of the treatment, as you're making the diagnosis, to be able to be on the be able to give the information to all the parents and the caregivers about what the diagnosis is and what the treatment options are that are available. It's also important to be able to tell them the harm and drug interactions of some of the herbal therapies. In our setup, we have seen herbal therapies causing renal failure. We have seen herbal therapies causing very bad Steven Johnson syndromes. We've seen herbal therapies causing very bad acute liver injury. We know that the parent is doing this with all the intention to save the life of the child. So we need to have empathy, even as we are explaining this to the child, to the parent. And so that the thing is that you need to educate and re-educate. Every session you have with them should be a time of educating them, allowing them to ask questions, allowing them to know the options available so that they are on the same page. But if you come very quickly, sura ya kazi, finish the word round and go to the next patient, the patient this parent has many more advisors. They have more advisors who will tell them, maybe try this, try that, try this, try that. And they're desperate. They want their child to live. And so that's why they'll go to the herbal therapies and everything. But if you explain everything very well at the beginning and continue making sure that they are able to ask questions, they can contact you at any time, they can ask for clarifications, then you will find that even they will be empowered to know that there may be harm in some of these therapies. And when they know that you're open and that you're honest, and you're telling them what is the standard of care, you're able even to Google with them and show them the standard of care. You're able to even Google with them to see the adverse effects of some of the herbs that they're using or some of the other therapies. Then you will be on the same page. And because all of them, the child, the parents want the best outcome. So you have to work with them, you have to communicate with them, and you have to make sure that you're on the same page and always empathize with them. Always empathize with them so that they know that you have the best interests of the child and work together as a team. And let them feel free to ask you even what may appear as stupid questions. Let them ask so that if they have relatives who would want to speak to you, let them feel free to call you and you can discuss with them so that maybe that relative can even explain to the parent that whatever you're doing is in the best interest of the child. Thank you.
Thank you, Dr. Meda. Yeah, we need to converge our interests together and let parents know that they should not see as if they are victims in the process. Allow me to welcome Elizabeth Kaputhi just to share our experience in monitoring and referral, especially in the context of play therapy. Please.
Thank you, Koima. And thank you, Dr. Omido. That was a wonderful presentation. Listening to you opens my mind to so many things that we can do for children. And sometimes we imagine that children do not have feelings, but actually they harbor a lot of fears within them. So in the holistic care of a child, it encompasses attention to the child's relationships, hopes, fears, and wishes. And even at this moment when these children could be in end of life on palliative care, they reveal their hopes and fears through play. And so I like it so much that Dr. Omeda, you have spoken widely about the importance of play therapy and the importance of art therapy. I was listening to you talk about the child with Down syndrome, the one who was using black color. And you know, when a child is injured, when a child has emotional injuries, since they have limited vocabulary, they are not able to, verbalize appropriately using words about their feelings. So art comes in very importantly. And so you can even see by the strokes, the way that child is holding that crayon. Are they holding it in a very firm grip, or are they using light strokes? When a child is using very deep colors, just the same way Dr. Omido has spoken about the dark colors, that means that they feel dark in their hearts. But when you see a child start using colors that are bright and child-friendly, and they are using lighter strokes, it means that they are able to debrief themselves and start on the recovery journey. And so also additionally, the importance of music therapy, even in that moment, that golden opportunity when a child is dying, and sometimes we may lack words to say. Maybe there's somebody in the room who is praying, or sometimes during anticipatory bereavement sessions, we have prepared the parents for the eventuality. And so even when a child is dying, there's so much calmness in that room. Music therapy comes in strongly. And it is so beautiful to see that golden opportunity, a child smiling just before they die because they are appreciating the beauty of music therapy. So there are so many amazing ways in which we can utilize, and I appreciate you, Dr. Omido, for bringing all these ways into the fore and making people understand that actually there is always something small and something beautiful that you can do to even that child who is in end of life. So thank you.
Yeah, thanks, Liz, for sharing that. Edgar had raised his hand. I don't know whether you still have a question or it was answered in the course of the discussion. Okay. Any other comment, questions? You can just raise your hand. Yes, Dr.
I've seen Margaret Mogaka on the call. She's one of our nurse psychologists who has been practicing the art therapy and anticipatory bereavement counseling for some of our clients. Maybe she could say a few words that can show that these things are possible, even in a county hospital, even in a setup that may not be very ideal. It is possible to actually intervene and make a big difference in these children.
Thank you very much, Margaret. You're welcome. Just in the context of our county referral hospitals. Margaret, is she in the? Maybe you will alert us so that you can share as we go along. Any other question, comment? Just let us know. We will unmute and you share experience. Let's listen from Kehpca. How are things there? Okay, so maybe somebody will share later on the Kehpca context. We are still ready to receive your comments, questions. You can raise your hand and we will be able to cue you in to share ask your question or make a comment or share experience. I mean, it's a wide topic. From now, having even Dr. Medo answering those questions, it's a wide discussion. So I encourage us just to share our experience from where we work, how it has been for you, and we just want to build the conversation around communication to these children. Maybe as we prepare, I don't know, Dr. Esther, are you? Yes, sorry. Go ahead.
Just to also thank you, Dr. Omedo, for highlighting very key issues that we had not thought about when we talk about communication. Usually we just think it's about talking, but issues like environment and clothing and things that we can really make a difference about, we never thought about them. So thank you so much for that. There's a question which I've seen happen in some situations where we talk about, okay, usually in research, but I'm sure maybe in practice, where they say that a child has to give an assent, and then the parent gives consent, maybe for an intervention or for something to be done. So what happens in a case where the child assents to a certain intervention or a certain accents to something, but the parents have not given consent to it? So in such situation, how do you handle that, especially for children maybe above 12 years who are sober and want something done in a different direction? Thank you.
Thank you for that question. The Kenyan Constitution makes it very clear that the best interests of the child come as a priority. So if a parent wishes is against the best interests of health for the child, then you're legally allowed to make sure that the child gets the best despite the parents' disapproval. However, most of the times, most parents want the best for their child. So if you find that they are refusing something, you might find it may be a matter of miscommunication. And maybe what may be important to do is to sit down with the parent once again and be able to find out what they know about the situation, what options they propose, the advantages and disadvantages of the options that they are proposing, so that in the end they come to an informed choice and realize that you are on their side, that you're not against them, but you just like them want the very best for their child.
Yeah, thank you, Dr. Medo, for answering that question. There is another question. I'll just read as it is. How do you break bad news to the family and caregivers of a child who are in denial? I mean, in the family could be in denial, or a child is in denial of the disease. How do you break bad news?
Yes, that's an important question. So first of all, you need to, you as the healthcare worker, need to get the full history again. Get the full history, do the full physical examination, through the treatment sheet, see did anything go wrong in the management and all that, and then now fully appraise yourself with where you are. Then make sure you have updated yourself, even if it means networking, speaking to other oncologists and other specialists, even elsewhere in the world, to find out what are the options when you reach in a situation that you have reached. So that you can make sure that before you address the family, you are aware of everything that was done, everything that could have gone wrong, and what are the treatment options in the current situation all over the world and in your country. So that then make sure that when you're meeting with them, you're in a quiet place, a place where everyone is seated down, a place that is relaxed, where there is no phone calls coming in and on, or people coming in and out, a place where you can have positive family conference. So before you start, you must listen. As we said, we're given 2 ears and 1 mouth. So you want to listen to them. And you want to listen to them and by hearing, how did this disease start? So that you can hear their side of the story, from where it began up to where we have reached. And so that you can get a clear understanding of what they believe is the process of where it started, where it ended, and where we have reached. Then now, once you have listened very carefully, you now, using the information that you have had from them appraise them on what is the current situation right now. And then now you are able to tell them on what the treatment options are available at that point in time, so that now they can realize that this is the dire situation that you are in. So denial is a normal reaction to bad news. It's a protective a mechanism that each and every one of us sometimes goes through whenever we have bad news. So you have to empathize with them and know that it is part of the bereavement process. However, you want to be able to appraise them with the right information of the current situation and make them feel that let them know that their feelings are validated, that it's okay for them to feel bad about it. It's okay for them to feel afraid, and let them know that you and your team are ready to work with them, even in this difficult situation, even in this situation that didn't go as we had planned. That you will work with them to make sure that there's a peaceful outcome for the child, even at the very end. And in your own time, you could also get a chance to listen to the child as they tell you about their disease process, and hearing for them what they think about what is going on and what they would like to be done. It's important to hear their point of view. And sometimes it may be important for you to communicate their point of view even to their parents, and so that you have a shared discussion and a shared plan that will work in the best interests of the child.
Thank you, Dr. Dr. Medo, one direct message to me, and somebody gives two scenarios and request for your comments. Says a child done nephrectomy in a certain facility and was told we have removed the tumor. 3 months down the line, a regrowth. Another scenario, a child comes with a fracture, done ORIF, and that was the problem. Some months later, comes back with a tumor regrowth. So this person is asking, how do you navigate those scenarios? Because the parent already has information that we have either removed the tumor, we have corrected what is happening, and then later the tumor recross. Your comments, Dr.
Thank you so much for that question. It's a very important question. One thing we must remember as Kenyans is that pediatric oncology has been a neglected specialty for very, 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 very many years. And so there have been very few pediatric oncologists. And so there's a general ignorance about pediatric oncology, even among health workers, even senior consultants. Many of them do not have the updated knowledge on the treatment protocols in pediatric oncology. And that is something that we need to work hard to change, even using these eco sessions. And even in our medical schools, we need to now make sure that people are updated with the latest management of pediatric oncology cases. And that means we need to have more and more multidisciplinary tumor boards with the surgeons, with the different people, the orthopedic surgeons, with all the different people who encounter these children who have cancer or other life-threatening and life-limiting situations. So one of the things to say is that is to understand that possibly that doctor may have acted to the best of their knowledge, not knowing that there were other things that needed to have been done after the nephrectomy. The histology needed to have been done, and maybe chemotherapy needed to have been instituted. We have to remember that for many years there were hardly any pediatric oncologists, so the surgeons were on their own trying to manage these cases on their own without much support. And so there's need to educate the health workers about the importance of histology, even in what seems to be a trivial or straightforward surgical case, and that after the histology, it is important to link up with the oncology team, even in advance, so that the chemotherapy or whatever else that is needed or other investigations that will be needed can be instituted in good time. So as we have said, honesty is the best policy. It's important to ensure that your colleague maybe did not have a bad intention. They did their best according to the knowledge that they had. However, there was more that needed to have been done in such a situation. And then now when you realize where you are, you stage appropriately and then try to institute the care that can still achieve cure, even though the disease is more advanced than it should have been at the time they sought care. And then make sure that you give positive feedback to the team that had managed the patient before, and don't do it in an accusatory way or in a condemning way that's saying, oh, that daktari ni bure sana hajui chochote. No, that doctor tried their best within their knowledge. The thing is now to give them positive feedback that next time when you get such a tumor, it's important to do this and that, and to make sure that the oncology team is involved in time so that the disease can be cured. So giving positive feedback is very, very important. And then we need to work hard now that God has helped us get a sizable number of pediatric oncologists. We need to really work hard in educating people through sessions like this and even other sessions to make sure that other specialties are praised in the latest management of pediatric oncology and other life-threatening pediatric cases. Thank you.
Thank you, Dr. Simply put, awareness on childhood cancers. Dr. This one is a very important one, touching on us, and I think it's from Maculine. How can we streamline communication and hand over, as sometimes we ask parents and children the same questions many times on different occasions? And let me, you posed that question, let me put it even this way. Many times we have different discussions in different ways, and caregivers or even these children get different information from us differently. So how can we streamline that in terms of transitioning of information from one healthcare worker to the other, or even from a department to another department? How can we make that good, Dr.
So the importance of multidisciplinary tumor boards cannot be overemphasized, and even in ward rounds, making sure that there's a common understanding among all the healthcare workers. Sometimes in our hospitals, we do ward rounds like in silos, doctors peke yao, nurses peke yao, physiotherapists peke yao, the psychologists peke yao, and which is not good. We need to work as a team so that every voice is heard and everyone is in synchrony in understanding where things are, so that we're not giving conflicting messages over the situation. It is true, different health workers may have undergone different experiences on different conditions. Some of them may know some information, and some of them may lack some of the information about the latest in the care of different conditions. So some of them may be advising with the knowledge that they have that it probably is not updated to the current knowledge that there is. So it's always important to have an open door policy so that people can feel free to ask questions during ward rounds. People can feel free to come back and even talk to you privately over the condition of the child. And that if there's any question in the management they are feeling doubtful about, or they're feeling insecure or not comfortable about, you can be able to listen to them, find out what their insecurities are, give them information that can make them now more confident about their treatment. And then later on, you find they'll come on board. For example, when we had started managing children with cancer in our wards, everyone was very afraid. They did not want it. They didn't think it is not possible, and all that kind of thing. There was all that fear and insecurity among the staff. But later on, when they watched those tumors going down before their very eyes, and the children becoming cheerful and realizing that pediatric cancer is not necessarily a death sentence, that children can live and thrive even with the cancer, you could see the big difference. The fear that they had was gone, and they all became allies in supporting these children and their families and following up and finding out how they are doing. And so we need the same even with the people in administration, the board members of hospitals, the administrators of hospitals, for them to be updated that pediatric cancer is something that is treatable, and that they should support the staff in making sure that all the conditions are there necessary for us to be able to do what we have been trained to do very well, so that many and more children can be diagnosed in good time and can get the right treatment in good time. So the thing is to acknowledge that the person maybe is trying to say their best according to what they know. Their opinion is valid. However, you can educate them so that their knowledge is updated, and then they can come on board and realize that there's more that can be done than what they had thought. Thank you.
Thank you so much, Dr. Medo. Just in summary, honesty is the best policy. Let us advance on awareness, leverage on MTDs and tumor boards, and just let's keep talking. Let's keep sharing using these platforms. There are so many platforms which we are in it, and let's just engage in that platform. I want to thank you so much for your time this evening, Dr. Medo, for sharing this very important topic. And as all who have been participating through this discussion, I am so grateful that you joined us this evening. My name is Raphael Koima. I've been your moderator. I would love to take back to Emily and the team at Kehpca. And thank you, Kehpca, for facilitating this. We would love to see more of these webinars in the future. Thank you, Emily.
Thank you very much, Raphael, and thank you to everyone who joined, Dr. Deborah and Elizabeth, for sharing. We truly appreciate. So this is to thank everyone for joining. Wherever you are, I believe that you have learned a lot, not a bit, but a lot, on how best we can take care of our children. I know there's a question, but I promise that I will bring Liz back soon, very soon, and she will answer that question. Yes, so we were to end at 8:30, so allow me to end it at there. We have a series of webinars that are coming up. Next month, we will have one, and kindly look out at our pages. We will be posting them. We have one on how to neonatal palliative care, and another one on pain management in children. So be on the lookout as we learn more about palliative care and how best to handle our children. So I thank you everyone for joining, and see you on our social media pages. Please ensure that you follow us there. So thank you very much, and we are all allowed to leave.
Thank you, Emily, and good evening.